Good morning. This is Alice Lind at the Healthcare Authority, and we welcome all of you to the Learning Collaborative webinar this morning. I wanted to just do a couple quick updates and review of the agenda before we get started. Before we turn to any of our speakers, I want to first ask our webinar host to explain how you will need to pose questions during today's webinar.
Hi everybody, so if you have questions during the webinar, if you look over to your webinar panel, there's a questions drop-down box. You can send in all your questions through that box and we will either answer them as they come or answer them during the designated Q&A period.
Thank you. So today's webinar is being recorded, and we're going to go ahead and get started. We have 50 people on the line today, several speakers, and then I noticed that we have representation from many of our regions who are going to implement integrated managed care in 2019, as well as the managed care plans. In way of background, we have received many questions about the requirements for delegation, especially under NCQA standards between the managed care plans and their contracted entities. If you are familiar with the first two procurements and the integrated managed care contract that Healthcare Authority has in place, we conveyed the message via that procurement and contract that we really do prefer the integration of essential behavioral health functions at the MCO level. And in the contract, we spelled those out as to include utilization management, grievances, network development, quality management, claims management, et cetera. And our reasoning for that was that we felt that administrative streamlining and the avoidance of duplication of those functions would be helped with our trying to convey that message. And also because we have seen in some states where the goal of the state agency was to integrate at the managed care level, but then when the MCO turned around and carved all those services back out again to a separate entity, it didn't achieve the results that the state agency was hoping for. We really were hoping that by combining all administrative functions that it would serve clients and providers better. However, we do realize that with the transition year option, that the delegation of some of these essential behavioral health functions will be necessary, and even ongoing, that as behavioral health crisis services are a subcontracted function, some of those services also require delegation of some functions. And we will have ongoing monitoring of how subcontracting and delegation of functions takes place. Still, our philosophy hasn't changed. Our goal is to minimize duplication, to minimize the burden to providers, and to increase the support for clinical integration. And we feel that treating enrollees as whole persons with access to a seamless continuum of services is best served by having as many of the functions integrated as possible. That being said, with all of the swirling around the delegation requirements, we thought it would really help to have you all have some basic educational background on the delegation requirements under NCQA standards and how the MCOs hope to assist you with delegation between now and 2019. So on today's agenda, the first good chunk of time will be for NCQA to go through their delegation rules and requirements. They'll talk about some variations that are allowed for accredited entities, some examples of models that can support integrated managed care. We'll pause then for some questions from you all, and just to reassure you, we will be sending their slides out following the webinar. And in advance of today's webinar, we sent out an acronym list. We thought that that might help you keep track of the topics that they're talking about, because certainly we're getting pretty acronym heavy at the Healthcare Authority, and so we just want to make sure that you all have a handy reference tool for that. Following NCQA's presentation, we also will have the MCOs present. We have a volunteer from CHPW and Molina today who are going to go over MCO delegation tools and their plans for assisting folks with delegation. And then we'll take some more questions on that and close up at 12:30. So thank you very much again for all of you jumping on the webinar today. We're really excited about being able to present this material. So with that, we'll turn to Leticia Adai and Ann Carson from NCQA, and your slides are up now, and Leticia and Ann, please take it away.
Latisha, are you all set to start? Latisha, you're still showing on mute. This is Ann, everybody. I'm sorry. She's going to get us started. But...
Hello, can you hear me? Hello?
Can
you hear me? Okay, sorry about that. Welcome, everybody, and thank you for having us this afternoon. My colleague Ann Carson and I will be spending a little time with you today talking about some of our NCQA standards and delegation requirements. Next slide. I will begin the presentation with a short introduction to NCQA, a review of the delegation and automatic credit requirements, and will then give you an overview of our accreditation requirements, and then we'll leave some time at the end to address any questions that you have. We do have quite a bit of information to share with you today, so we're not going to take a break in the middle. We're just going to go through the entire presentation, and then we'll have some time for questions at the end. Next slide. As was mentioned earlier, we have provided a list of acronyms that are commonly used at NCQA and are used throughout the presentation today. I know that you probably have your own set of acronyms you have to memorize, so I don't expect you to memorize ours right away as well. So I'll do my best to make sure and spell out or say what the name is as I go through the presentation so that you're not having to guess what I'm saying. Next slide. So who is NCQA? NCQA is the National Committee for Quality Assurance, and it is a private, not-for-profit organization that is dedicated to improving healthcare quality through measurement, transparency, and accountability. NCQA began its accreditation program for health plans in 1991 and now offers accreditation, certification, and recognition programs in a variety of healthcare for a variety of healthcare organizations, including health plans, managed behavioral health organizations, or MBHOs, certified credentialing verification organizations, or CVOs, utilization management, and credentialing organizations. Next slide. So let's get started with the main focus of our presentation today, which is delegation. Next slide. As part of this presentation, I will provide you an overview of our philosophy regarding delegation and the responsibilities of the delegating entity, sub-delegation and how that works within the framework of delegation, how NCQA evaluates delegation, including implications for file review, And finally, some of the common pitfalls and keys to success. Next slide. So what do we mean by delegation? Delegation is the formal process by which an organization gives another entity the authority to perform functions on its behalf. Although an organization can delegate the authority to perform a function, it may not delegate the responsibility for ensuring that the function is performed appropriately. Bottom line, organizations are accountable for any function they have someone else perform on their behalf. This aligns with NCQA's mission, transform healthcare through measurement, transparency, and accountability. And this is part of that accountability. Because the delegation standards are identical throughout each standard category, so in the health plan standards and guidelines, we have different standard categories such as quality improvement or QI, utilization management, or member connections, MEM. So this session is built to discuss delegation broadly and is applicable to any type of delegation within the NCQA standards. Next slide, please. So this slide just provides you with a non-exhaustive list of the types of delegates we typically see. So these may include medical groups, managed behavioral health organizations, MBHOs, credentialing verification organizations, CVOs, pharmacy benefit managers, and some other organizations that are listed here as well. Next slide. So figuring out when delegation exists can be challenging for organizations. So this just gives you some examples of delegation. So the first example is a scenario in which a health plan would delegate to an MBHO or a managed behavioral health organization that so that the MBHO can identify and contract the MBHO organization identifies and assesses eligible members, which is part of our PHM5 requirements for complex case management. In the second scenario, or in the second box, middle box, this is another example of where a health plan might delegate to an MBHO to investigate and respond to member complaints about behavioral health practitioners, which aligns with some of our requirements in Net 2, Element B. And finally, the third or last box deals with a health plan that may delegate to an MBHO that performs some UM-related behavioral health care approvals or denials for the health plan organization. This aligns with some of our requirements in UM5 and 7. So one way of deciphering if a function or activity is considered delegation is to think of it as a function or activity that an organization would have to perform in order to meet an NCQA requirement if it did not use or delegate to another entity. So these examples on this slide are clearly things within the NCQA standards that an organization would be required to perform. Next slide. So let's talk about an example of non-delegation, something that would not be considered delegation. An MBHO is performing its own quality improvement activities that's independent of the health plan organization that it is contracted to work with or is working with for other services. If the health plan is performing the required NCQA QI functions itself, and even though it's working with a managed behavioral health organization that might be performing these functions on its own, but because the health plan hasn't specifically delegated those functions to the MBHO, NCQA would not consider it delegation for purposes of that health plan survey. So if a managed behavioral health organization, for example, monitors behavioral health appointment access, but the health plan does so as well and hasn't delegated this function to the MBHO, The fact that the MBHO is doing it too does not make it delegation for the, in terms of what the health plan is required to do for NCQA purposes. So another example that is not considered delegation is related to transportation services. So transportation services are not addressed within NCQA standards, and therefore this activity for purposes of the health plan survey would not be considered within the scope of delegation. So if there's anything that the plan is doing that are not within the NCQA standards or is not an NCQA requirement, for our purposes, we would not consider that to be delegation. Next slide. So now we are here and talking about subdelegation. So subdelegation occurs when an organization gives a third entity the authority to carry out a function that has been delegated by the organization. Subdelegation is perfectly okay with NCQA. However, if a delegate subdelegates to another entity, it must be clear within the delegation agreement which entity is responsible for overseeing the subdelegate. Either the health plan or the delegate may oversee the subdelegate, but the subdelegate's performance must be evaluated in the same way oversight is performed for the delegate. It's also important to note that the subdelegate's performance may be reviewed by NCQA and may impact the health plan survey. NCQA will ask organizations to provide the names of all its delegates, its subdelegates, during the survey process. So both delegates and subdelegates would have to be provided to NCQA during survey. Next slide. So this slide just provides you with the visual of subdelegation. In this scenario, there is a health plan that delegates credentialing functions to an MBHO or a managed behavioral health organization, and subsequently that organization subdelegates some of those functions to a credentialing verification organization. So this is just a picture of how you might visually imagine subdelegation to work. Next slide. So while there's certainly many requirements in the standards that can be delegated, there are actually quite a few requirements that cannot be delegated, and we've listed them for you here. You'll notice that the majority of these requirements are in the delegation oversight requirements. You cannot delegate delegation. NCQA expects organizations, for the most part, to complete these functions or activities themselves. The other requirements listed, such as PHM3B, and which is our Population Health Management Standard category, or RR1A, which is our Member Rights and Responsibilities category, cannot be delegated as well. The organization cannot contract with another organization to perform these functions. The list of requirements that cannot be delegated are available in the delegation appendix of both our health plan and our MBHO standards and guidelines in Appendix 5 and 3 respectively. So I just want to mention quickly before we move on. So while these are requirements that cannot be delegated, including delegation oversight, we do allow when an organization delegates to a delegate and the delegate subsequently subdelegates to another entity, it is possible for the delegate to either oversee its subdelegate or the organization itself, the health plan, to oversee its subdelegates. But whatever decision is made in terms of who is overseeing the subdelegate, everything needs to be outlined in the delegation agreement. Next slide, please. So let's move on to a discussion on delegation oversight. The list at the top here from QI7 through MEM5 just gives you the reference for all the delegation oversight standards within each standard category. So the first is QI, which is quality improvement. PHM is our population health management standards. Utilization management, our network adequacy standards, our credentialing standards, our member rights and responsibility standards, and our member connection standards. So as I mentioned before, for each standard category, the delegation oversight requirements are pretty much the same. There are a few differences that I'll try and point out to you, but for the most part, these requirements are the same across all standard categories. Next slide. So delegation oversight is important because as an organization, you should be monitoring your delegates' performance for consistency with your PMPs and just to make sure that your delegate, the organization you've contracted with, is performing the functions the way you have agreed. So another point to remember is that your delegate's performance may be assessed during survey under NCQA standards. So conducting strong, good oversight is important. How might a delegate's performance be assessed? Well, for non-file review standards, if the delegation covers greater than 30% of your membership, you may be asked to submit sub-delegate or delegate documentation. For file review standards, strong ongoing oversight is particularly important. So for example, if you have not been overseeing your delegate properly and files are not compliant with NCQA standards, any of their files that are included in the organization or the health plan's file review will count toward the organization's performance. So if they did well, that's good. If they don't do so well, then that's not so good. So if an organization delegates credentialing or functions to a delegate, but finds out just before survey that there are issues with those files, like maybe some of the timeliness requirements for have not been met, this is a delegation oversight failure, and it may be too late for the organization to correct the issue. Next slide. This slide just provides you an overview of all the delegation oversight elements within the delegation oversight standards. And I'm going to address each of these separately in the subsequent slides, but there's a standard or an element, in the delegation oversight related to the written delegation agreement, provision of member data to delegates, provisions for PHI, a pre-delegation evaluation, annual review and audits, semi-annual reporting, and opportunities for improvement. Next slide. So let's start with the delegation agreement, which applies to all delegation relationships, regardless of whether an organization is working with an NCQA accredited or certified delegate. The agreement is core to everything else that follows. And we'll start with factor 1. The agreement must be mutually agreed upon. Organizations typically demonstrate mutual agreement in a binding communication that is signed and dated by both parties. For factor 2, NCQA's expectation is that both the organization and its delegates' responsibilities are spelled out in the agreement. Sometimes organizations will think it's sufficient to simply list its delegates' responsibilities, but this is not enough. The delegation agreement must specify the responsibilities of the organization, its delegate, and any subdelegates. It's also not enough to just say, we delegated or we delegated credentialing. It must be very clear which entity is performing which function. Is the organization performing the functions in 5 element D, which is related to timeliness of or notification, of behavioral health care decision, or is it the health plan? Spell out the details. At a minimum, the agreement should specify any activities that are not listed as delegated but are retained by the organization itself. Let's move on to factor 3. Be clear on the reporting frequency and specific about what is required to be reported, who it's being reported to, and in what format. In factor 4, it's important to describe how you will provide oversight and the process for monitoring and evaluating the delegate's performance. Finally, with factor 5, what kinds of corrective action might you take if the delegate is not performing? The delegation agreement must specify the consequences the organization will take if its delegate fails to meet the terms of its agreement and the circumstances that would cause revocation of the agreement. Next slide. So this slide provides information on an additional requirement that is specific to organizations who delegate credentialing. Delegation agreement must state that the organization retains the right, based on quality issues, to approve, suspend, and terminate individual practitioners, providers, and sites if it has delegated decision-making. This is not a requirement or is not applicable if the organization has not delegated credentialing decision-making. Next slide. So this slide provides you with an example of how an organization might document its delegated activities. This is a good way to address factor 2 from the previous slide, which is related to the delegate's responsibilities and the organization's responsibilities, but it can also be used as a way to document the remaining factors. You'll notice in columns 2 and 3 of the grid, the organization has detailed its responsibilities and those of its delegates. So here the health plan maintains accountability for management of all member complaints, but the delegate is responsible for annually analyzing participant feedback within the complex case management or CCM program. So I want to also focus your attention on the last 3 columns: frequency of reporting, evaluating performance, and corrective actions. You'll note that the detail specificity around reporting. The column includes information regarding what the report will include, whom it will be provided to, and how it will be reported, which in this case was electronically. And then the last columns discuss annually evaluating the delegate's performance through an audit and review of reports, corrective actions that might be taken if the delegate fails to meet the terms of its agreement with the health plan. Next slide. So the delegation oversight standards all have the requirement that is outlined on this slide. The organization must provide information to its delegates when requested about member experience data and clinical performance data. An organization is required to either allow its delegate to collect performance data necessary to assess the bulleted information here, or share the information with their delegates when requested, so the delegate may assess its performance. We expect to see a process that the organization uses to show us how it shares information with its delegates. Additionally, we look to see, we look for evidence in the form of a report or materials that show us, are we okay? Okay. That show us that it is executed in its policies by sharing this information if applicable. The only standard category that this requirement does not apply to is credentialing. So just keep that in mind. This requirement does not apply when an organization delegates credentialing functions to another entity. Next slide. So let's talk about PHI for a second. The delegation agreement must address provisions for protected health information, or PHI, and most of the time a standard business agreement will include provisions for PHI, so it's not usually a problem for organizations. But under NCQA requirements, the following PHI provisions must be included: a list of allowed uses of PHI, a description of delegate safeguards to protect information from inappropriate use or disclosure, a similar description or stipulation for subdelegates, a stipulation that the delegate will provide individuals with access to their PHI, a stipulation that the delegate will inform the organization of inappropriate use, and finally, a stipulation that the delegate will ensure that PHI is returned, destroyed, or protected if the delegation is terminated. Next slide. So there are some exceptions to this PHI requirement. So provisions for PHI may be not applicable if the delegated functions do not involve the use, creation, or disclosure of PHI. But remember, it must be documented in the delegation agreement if the delegated functions do not involve these the use, disclosure, or creation of PHI. And then the requirement that the delegation agreement includes provisions for PHI is also not applicable for covered entities. under HIPAA, so such as medical groups, PBMs or pharmacy benefit managers or other health plans. Our recommendation is, as an organization, you may want to take the time to talk with your legal or compliance departments to determine if a delegate is a covered entity and would therefore be eligible for the exception. Next slide. So moving beyond the delegation agreement, a pre-delegation evaluation must be conducted by the organization for any new delegation agreements initiated in the look-back period in order to determine the delegate's capacity to meet NCQA's requirements before delegation begins. So the look-back period is, that's a phrase that NCQA uses, so I just want to define it a little bit. It's the period of time for which an organization must demonstrate performance against the NCQA requirement. The look-back period for first surveys, which is the first time an organization may be coming through the survey process, is typically 6 months. And then the look-back period for renewal surveys, so this is an organization that has been through the process before and they're coming back through the accreditation process again, is typically 12 months. The pre-delegation evaluation should look at the potential delegate's capability to conduct the functions and can be done in several ways at the discretion of the organization. So they can do it through a site visit, documentation review, committee meetings, any way that the organization deems appropriate, as long as the findings are documented. It needs to be completed, this pre-delegation evaluation, before the effective date of delegation and cannot be conducted greater than 12 months prior to delegation beginning. NCQA considers the date of the agreement to be the implementation date, and if this is in the case of no implementation date being specified in the agreement. A pre-delegation evaluation must also be conducted if an organization amends an agreement to include new activities. So please note that if your organization is working with an NCQA accredited organization, such as another health plan or an MBHO, NCQA will score this element 100%, and NCQA would not need to review any additional evidence of a pre-delegation evaluation. Next slide. So let's continue our discussion with ongoing oversight of the delegate by reviewing the element that requires the organization to review, audit, and evaluate its delegates. So we'll begin with the organization's responsibility to review its delegates' program policies. This is separate and apart from the requirement that organizations annually evaluate delegates' performance against NCQA requirements. This requirement applies to all delegation types except for rights and responsibilities and member connection standard categories. The requirement only applies to delegation that has been in place for 12 months or longer. There's no automatic credit available for this requirement. It is one of those requirements that all organizations are required to meet, even if it delegates to an NCQA accredited or certified organization. Review of program policies must be conducted annually and must be documented in some way. So, for example, via your committee minutes. If the function delegated is very specific, like if the function that you're asking another organization to do on your behalf is very limited in scope, your organization only delegates pharmacy recall requirements, for example, then your organization would only need to review the policies related to those requirements. Next. All right. So for first and renewal surveys, organizations are required to conduct an annual evaluation and file audit if the delegation includes files. The annual evaluation and file audit are two distinctly different requirements that must be addressed by the organization. For annual evaluation, generally the organization will have to have an audit tool of some sort, and they will use this to evaluate their delegate. Any delegated function should be part of the organization's evaluation process. Now, NCQA will give organizations a yes for both the annual evaluation and the file audit if the organization is working with an NCQA accredited or certified organization, if their accreditation includes the functions that were delegated. But please note that for both the annual evaluation and the file audit, the organization bases or has to base its review on the responsibilities that are described in the Delegation Agreement and the appropriate NCQA standards. Next slide, please. The key to understanding the reporting requirement for delegation oversight is that the organization must not only receive regular reports from its delegates, at least semi-annually, but the organization must also demonstrate that it evaluates those reports and reviews and analyzes them. And all of this is documented. So it's not enough to just get the reports, but you also have to do an analysis and review of them. This requirement is applicable to delegation arrangements in place for 12 months or longer. Organizations are not able to receive credit for this particular requirement if they're using an NCQA accredited or certified delegate. So delegates must provide these reports and organizations must analyze them. Next slide. So as a result of the oversight the organization has been conducting, all the stuff that we've just gone over, the annual audit, file review, review of reports, all of this information NCQA anticipates will help the organization determine if there are any opportunities for improvement that have been identified and any actions that would need to be taken on these identified opportunities. Any actions taken should be documented. And in the rare instance, in the rare circumstance that there are no opportunities for improvement identified by your organization, NCQA will apply and not applicable for this requirement. However, we will evaluate whether this conclusion is reasonable given assessment results. Now, this requirement applies to delegation arrangements that have been in effect for more than 12 months. And again, in this particular case, if an organization is working with an NCQA accredited or certified delegate, then the organization is able to receive 100% for this requirement. Next slide. So in closing, we're getting towards the end here. In summing up our delegation discussion, I just want to mention that NCQA will review a random sample of up to 4 delegates against the delegation oversight requirements within each standard category as applicable. And if an organization uses less than 4 delegates, NCQA will evaluate all the delegates. And this is applicable across all standard categories. Next slide. So I just want to briefly mention that one of the main advantages of a health plan using a NCQA accredited or certified organization is the availability of automatic credit. Automatic credit is equivalent to scoring a requirement as met. However, specific criteria must be achieved or met in order to receive automatic credit, and these include the need for a signed delegation agreement before submission of your survey tool, that your delegate is NCQA accredited or certified before your organization submits its tool. Your delegate's accreditation survey included the specific elements or requirements for which the health plan is seeking automatic credit. Delegation agreement describes the responsibility of the delegate, the organization, and any sub-delegates. For non-file review, the NCQA accredited and certified delegate must perform delegated functions for at least 70% of the organization's members. And then for file review elements, the NCQA accredited or certified delegate conducted the activities required by the element for the selected file. So for more information regarding delegation and the availability of automatic credit, please refer back to Appendix 5 in our Health Plan Standards and Guidelines and Appendix 3 in our MBHO Standards and Guidelines. Next slide. So thank you all for hanging in there with me. I know I moved through these rather quickly, and it's a lot of information. But before I leave, I just wanted to kind of wrap up and talk about some common pitfalls of delegation and how some organizations, some of the troubles or issues that organizations have with delegation. So one issue we often see is delegating to an entity that does not have the capability to do the work it is delegated to do, or the organizational structures are not in place to perform the delegated functions according to NCQA specifications, which may be more or less than you're required under other contractual obligations, but for NCQA's purposes, if you're going to ask an organization to perform functions on your behalf, you need to make sure that that organization is capable of doing the work. Now, another issue we see is not having the appropriate resources to complete the required delegation oversight, not being clear in the delegation agreement regarding who is responsible for performing which functions, the delegate, the sub-delegate, you just need to be clear who is doing what. Pitfalls related to delegation oversight include poor or untimely reporting by the delegate, failure to address any gaps in compliance issues. Maybe there's a lack of follow-through on corrective actions that have been identified of the sub-delegate. So you need to know what's happening with your delegate. Are they having some other entity do the functions you delegated to them, which is fine. We don't have a problem with that, but you just have to document and provide specific and clear delineation in your delegation agreement which entity is performing which functions. Next slide. So we went through the pitfalls, but I'm not going to leave you with just the pitfalls. I wanted to give you some keys for success. So you want to make sure that you have sufficient resources. Don't agree to delegate anything until you have determined that your delegate has the capacity to perform those activities. You have to be very clear on responsibilities and document those responsibilities in the delegation agreement. Make sure that the PHI issues are addressed. Make sure the agreement is signed and dated, demonstrating a mutual agreement. And finally, with oversight, just remember, meet with your delegates regularly to ensure that they are performing appropriately. Review and analyze your delegates' reports. Conduct your annual assessment and provide feedback, timely and corrective actions as needed. Thank you so much, and I'll pass things over to Anne.
Hi, this is Anne Carson, and I am in charge of training our surveyors and evaluating performance accuracy for our surveyors. I've been with NCQA for coming on 24 years and do a number of presentations and teaching on different topics. Leticia, I'm going to suggest that before we go into my section, where we're just going to kind of give a little bit of an introduction or overview to the standards and understanding them and how to put together the types of documentation we look at for compliance. Would it be appropriate to open up for questions on Leticia's presentation first? Because I think it's important that we make sure we have enough time for that in our agenda.
Sure. This is Alice. One question came in that I'm going to try to, first I'll just read you the question, but then I'll try to have you maybe answer it in a different way than it's being asked. So the question is, would NCQA be willing to contract with MCOs, BHOs, the healthcare authority, some combination of these entities to perform the BHO pre-delegation assessments and any ongoing monitoring for functions under consideration that involve NCQA requirements? And the reason for the question is that this approach would ensure objectivity and consistency consistency for all stakeholders, particularly as we determine how best to address the BHO transition during 2019. So I think, part of the question is, have you had experience with when this kind of transition is happening in other states where NCQA provides some support either to the state agency or the delegated entities or the managed care plans? I kind of doubt that you could actually do the actual assessment and monitoring for them, but you could talk about how you can offer support and training and assistance to ensure objectivity and consistency. So, Latisha, can you address that?
Actually, this is Anne. I'm going to take this one. We sort of traded some notes as you were asking. We've not taken a role like that in the past, or either serving as that direct evaluator, other than to the extent we accredit organizations, or contracted with a third party to be an evaluator. And some of that is finding sort of our balance as staying the objective auditor of our programs. It's not something we've done either in a capacity with a state or really with individual organizations in the past. We understand that what's going on with Washington and that transition that you're going through is a very specific period, and you're working through some very specific needs. And what we'd suggest is to have some additional conversations about what role we might be able to play with Christine and Jennifer offline.
Thank you.
Because we do want to support states, but it is something we've not done before, that we have something that's off the shelf that we can offer.
Thank you. I have another question. What is NCQA's estimate of the staff resources and the timeline it would take to ensure compliance with NCQA standards for a delegated function if the BHO has not previously considered NCQA requirements?
So I was the first one off mute, but Jennifer, do you want to take this, or would you like me to?
Hi, can you guys hear me? Okay.
Yes.
Oh, great. Okay. Hi, this is Jennifer Zutz. I'm the Assistant Director for State Affairs here at NCQA. We don't have concrete numbers on what the resources would be, but we estimate that it takes about 12 months to go through the process. And if you have any additional context for process, feel free to jump in, but that's generally what we're finding.
Right.
This is a hard question. This is Anne, because we do, we've been asked this, as I said, I've been here 23 some odd years, and I've been asked that question many times over the years. And I think the challenge we have in estimating it is every organization is in a different baseline when they start the process. And so the first step an organization should go through is to really, look at the standards, look at what we expect an organization to be doing, and to estimate sort of where you are. How many of these things as an organization are you currently doing, and what's within your sort of immediate capability? In other words, maybe you just need to write a policy and procedure because you're doing it, but you don't have it written down, or it's a small shift. And what are things where you might be putting in place whole new processes, and you've got to think about what that means for your organization. So the resources and effort it takes just varies so much. But what we do know is about how much time on the scale, as Jennifer said, which is usually 12 months, maybe up to 16 to get ready. And some of that is because we look for you to have certain things in place for a minimum amount of time before you go through survey.
Thank you. A question came in for us to respond to. Will the behavioral health organizations that are becoming behavioral health administrative service organizations, need to meet NCQA delegation standards to perform the 2019 transition year services. So the answer to that really will depend on what the MCOs delegate to the Behavioral Health Administrative Services organization. So again, back to the very beginning of the presentation, anything that the NCQA standards require MCOs to meet, if they delegate any of those functions to the Behavioral Health ASO, then Behavioral Health ASO would definitely need to be able to be in compliance with those requirements. So we can probably do some follow-up with you, or perhaps when we get to the MCO presentation, they can explain a little bit about what the sort of bare minimum is. For example, if all they were delegating back to you were management of crisis services, what sort of the bare minimum of being able to meet their requirements for NCQA. Another question for NCQA is, what delegation requirements are the most challenging for delegated entities?
Hi, this is Latisha. I'm going to say a few words, but then I'm going to ask Anne, who has a lot more experience with surveys than I do. And I'm sorry, I didn't introduce myself formally at the beginning. I am the Assistant Director of the Accreditation Policy Unit here at NCQA. I've been working with NCQA for about 6 years now. But I think the most challenging requirements kind of depend on the organization itself. I think it's really important, again, in terms of delegation and delegation oversight as an organization, to know who you're delegating to, understand, do that pre-delegation evaluation, and make sure that the delegate you're working with is ready and able to perform the functions that you're asking them to. Anne, do you have anything else to add to that?
Yeah, I would say it's not so much that specific delegated requirements are challenging. So for example, if utilization management is being delegated from a health plan to a behavioral health organization, that doing UM is challenging because UM is a function that a behavioral health organization does. Credentialing is a function that they, probably do depending on the way they're organized. So actually doing those functions is not the challenge as much as it is coordinating between the two organizations, because just because, Health Plan A delegates to MBHOZ doesn't take the health plan out of being responsible to make sure that everything's being done the way they want it to do. We talk a lot about our standards for delegation and oversight, but in the end, good delegation oversight is really about risk management on the part of the organization that's delegating. You have somebody else doing something, are they doing it the way you want? So the challenges are almost more in that relationship, in the plan staying on top of what the delegate's doing and being comfortable that it's being done well, and the delegate being able to provide that evidence to the plan that they're doing what they want. If that makes sense.
Yeah, thank you. We had a couple different questions about care management function, and here's an example of one. I'll just read it. Are NCQA care coordination standards needed with the care coordination that would transition to January 1st? And so just from one region's perspective, the MCOs would probably keep the majority of care coordination and not delegate a lot of it. But what is needed for care coordination connected to diversion or high-intensity services? So, for example, if the majority of care coordination is kept at the MCO level, but for high-intensity clients, people in crisis, people needing diversion, if they need care coordination services, then are there aspects of the NCQA standards that would apply to that situation?
Okay, so this is, yeah, go ahead, Leticia. You have, what you want to start with?
Yeah. Well, I was just going to say, I mean, it sounds like, yes, that is possible, but I think we would need more specific information. But we do have requirements in our PHM standard category regarding complex case management. So depending on what requirements within those standards are retained by the health plan and the requirements that the health plan maybe would delegate to a managed behavioral health organization, we would consider that to be delegation. And, because they're within our standards, we would expect the organization to oversee that delegate to make sure that those requirements are being met in accordance with our standards.
Yeah, and what I would add is, care coordination is such a broad spectrum. And traditionally, our health plan standards, we're actually just making this transition from focusing on wellness sort of as a very siloed approach and disease management as a siloed approach and complex case management, understanding that there's probably a gap between disease management and complex case management. To a more full spectrum approach, where as opposed to seeing those as siloed functions. But in terms of very specific care coordination, we've really focused more on complex case management, and that can be that's a pretty narrow population scope. We did in the last couple of years introduce an optional set of standards that focuses on LTSS services, long-term support services, and those standards do get into care coordination, but they're not standards that are required for a health plan to be evaluated on. But I do think that there are some care coordination areas that do touch more on the behavioral health area within LTSS, and those standards parallel both in the health plan and things that we evaluate MBHOs on. So as Latisha said, I think that we'd have to get into a little more specifics of whether or not a specific service is outside of our scope, but in general, we're focusing mostly on the complex case management side.
Great, thank you. A couple other questions that came in I think are going to be easier to answer perhaps after the MCO presentation, and the MCOs might be able to weigh in as well. So I think we'll pause there and go ahead and let you do the remainder of the NCQA presentation, please, Anne, and then we'll, people do please continue to send in your questions.
Okay, thanks. So you can go ahead to the next slide. So as I set this presentation up, I concluded after I did it originally that I might have set it up a little bit framing it wrong, but I'm going to do my best to shift on the fly. What we wanted to do was provide an introduction to the categories and the standards at a very, very high level. And then to the extent that one has to comply with the standards, it helps to understand how to read them, because we put information in certain places to try and help it make sense and so you would know where to look, and then also talk a little bit about documentation. However, what I did was I framed it in the scope of the MBHO standards. If you think about the world as being made up of a table with rows and columns, our health plan accreditation and our MBHO accreditation have very similar standards. Next slide, please. And in fact, many of them are identical, but we put them in different cells. We have some different categories. So for example, we have a care coordination category in our MBHO standards, and some of those standards are in population health management, which is a different category in health plan. So I put these in the context of the MBHO standards table. But as we talk through these, we're going to talk about how they work back and forth, or how they map back and forth between the two areas. And my goal is not to teach you all of the standards. To teach all of the standards in an introduction is about a 3-day program. And so what I want to do is just hit some high levels and then focus in on how to understand the information if you go read them on your own. Next slide, please. So the first category of standards in MBHO, and on the left side is some high-level areas that they cover, and on the right side is the categories they align with in health plan. We start at the top with the structure and operations of the QI program, and so we're looking to see that an organization has in place a program description and a work plan, and that program description and work plan address the resources needed for the QI activities, the scope of those activities, where does the QI program touch within your organization, and its accountability and governance. So how does it relate up to the management structures of the organization, and are there key practitioners, whether that's a medical physician on the health plan side or a behavioral health physician on the behavioral health side involved in the program. The next area that we transition into in the standards is network availability and accessibility. And these are actually in the network management category in our health plan standards. In the last 2 years, we created 2 new categories, and so some things in health plan have been mapped over that we haven't reorganized yet in behavioral health. Availability for us is whether or not when we think about the network, whether or not there are practitioners and providers in a specific geographic area that the organization sets for itself. Accessibility is the ability to actually get to a service. How many days does one have to wait? How long does one wait on the telephone when one calls a behavioral health triage line or a customer support line? We have member experience in our quality improvement area, and that focuses on both experience information gathered through surveys and also gathered by analyzing complaints and appeals. We do have a standard around behavioral health triage and screening. Not many health plans are requiring that anymore. MBHOs sometimes do still have that, although it's not as common as it was when I worked in an MBHO 25 years ago. But there sometimes still is a triage and screening requirement to access behavioral health services through the organization. And so we do look at that process if it's there. Complex case management, as we've talked about, and self-management, sort of wellness and health promotion activities to try and keep the member from progressing down that spectrum to acute disease, chronic disease, and potentially complex case management services. We look at clinical practice guidelines. Plans are required, or MBHOs are required to have clinical practice guidelines. It's actually not a standard in our health plan standards anymore because much of it aligns with requirements around HEDIS measures. And so we've taken that piece out, but it is still in behavioral health. And then clinical measurement and effectiveness. We actually are looking for behavioral health organizations to do, if you've heard the term QIA, the classic QI activity, to show us activities that they are doing specifically to improve clinical quality of care. We don't look at those activities discretely in the health plan side anymore because 50% of a health plan score is their actual performance on HEDIS and CAHPS measures. And so we're looking at their outcomes instead of looking at the process of QI. Next slide, please. So care coordination gets at coordination both within behavioral health care, and this is thinking about care coordination on a population-based level, and then also with medical care. So what's being done to measure coordination and continuity of care within the population as opposed to for an individual member or patient? Looking at transitions between different levels of care or sites of care. And then on the coordination with medical health care, what's being done working with, for the medical side, the behavioral health care practitioners and providers to improve coordination and continuity of care. If we're looking at a behavioral health plan, what are they doing to work with the medical providers? So that piece coming in from both sides. Continued access addresses if a member's benefits run out. So if a member has exceeded, say, there's a visit limit for a specific service or a day limit or a dollar limit, which a lot of that is less common than it used to be. What in place to help transition the member to additional care or maybe community resources. And also, if a practitioner leaves the network, continuity of care for a period of time while a transition is made. And then finally, technology and how technology is being used to help support continuity and coordination of care, drawing on similar expectations as one would see, for example, in a medical home model. So not that we expect a plan to function the way a medical home does, because it's not a direct provider of care, but what can be done using technology to help support those same systemized care ideas. Next slide. Utilization management is actually a pretty straightforward area. When we think of utilization management, we get to the sort of basic ideas of pre-certifying, pre-approving coverage for care based on medical necessity criteria. But we look to see that there's a structure and process in place to be sure that that's done in a way that protects the member's rights. So what's the structure for who reviews decisions, who can make decisions, who can make denial decisions, and we have very specific standards around that. The criteria used and assuring that there's evidence-based objective criteria to make decisions, and then the processes to actually make those decisions, both for first-level decisions and then appeal decisions. When a member requests an appeal of a denial of coverage for a service. And so those processes get into who reviews and makes decisions, how timely are they, and we have very specific requirements for timeliness. And then the notification, it's very important in NCQA's process that members be notified in very specific detail of reasons for denial, what they would need to do if they wanted to appeal, what their rights are, et cetera. We look at the member experience with utilization management in addition to broad member experience that I talked about a couple of slides back. Very specific experience with going through a utilization management process. Communication services, the ability for members and practitioners to access the department, and then also to get information on claims. So, you know, if a claim has been submitted, what's been paid, what's the status of it. And then finally, the triage referral process comes up here as well in the utilization management area. Next slide, please. Credentialing is, again, another area that when we think about it, it's pretty easy to picture what credentialing structure looks like. But we do look at the processes an organization has to bring both practitioners and providers into the network. Much of the standards in the credentialing area are very practitioner focused. The provider section is much smaller than the practitioner section. And we actually do pull samples of files for practitioner credentialing to look to see that a practitioner was credentialed consistent with the standards. And that's reminding me of a point I didn't make, so I'm going to come back in a moment to another slide. But so what are the policies in place about who should be credentialed, where in the processes for verifying that information, right down to, you know, to find out information about malpractice history, what are the steps that a staff member is going to go to get the malpractice history information for a specific practitioner while they're credentialing. The process to make decisions, which gets to the committee, recredentialing, the frequency at which practitioners are recredentialed, and all of those verification and recredentialing we look at in specific file samples. Ongoing monitoring, just because an organization recredentials a practitioner every 3 years, doesn't mean nothing happens for 3 years about that practitioner, because something can come up in between, whether it's a sanction by the state, a sanction by Medicaid, a felony conviction, what have you. We want to know that organizations have a process in place to be monitoring their practitioners in the interim. The process to notify authorities if they do find a quality issue and they're going to take action on a practitioner, and then also the appeal process practitioners have if there's action taken against a practitioner in terms of his or her network status. I'm going to skip back just briefly because in both the utilization management area and in the complex case management area, I did not mention, but those are two other areas where we do a sample of files. So for denials and appeals, we sample a selection of the actual denial decisions that are made and look to see that they followed the correct process and the member was given the right notifications. And similarly with complex case management, we look at a sample of complex case management files. So those are the other file areas. Do you want to go ahead? Next slide. Members' rights and responsibilities. We look to see that the organizations have a statement of the members' rights and responsibility, and that they distribute that both to members and to practitioners, so that everybody understands their role in the process of managing care. We also look for processes for and policies for handling complaints and appeals. And you'll note that appeals shows up here and in the utilization management section. The reason is we want to make sure the organization has processes for complaints and for appeals of two different types. An appeal of a coverage decision, but the organization also needs to address appeals that might not be of a coverage decision. So for example, some plans limit the frequency of which a member can change practitioners, can change primary care practitioners, or a decision that involves, say, a member who's coming to a health plan through an individual market who is dropped from coverage because they haven't paid their premium, and the member standing there and has a canceled check. There needs to be an appeal process for that, and that's very different than an appeal process that says we don't think a specific treatment or procedure is medically necessary at this point in time. So we want to make sure that the scope of the member's ability to appeal covers any decision a health plan makes. Information to the member and subscriber about the plan, how to access services, what their benefits are, and then finally directories for finding out who's in the network and information about the practitioners and providers in the network. We've got one last area. Next slide, great. Long-term support services. So long-term support services is a new area for us. Many states are bringing this into the Medicaid plans, and so we've put in place some optional standards. They focus on the structure and the process of the LTSS programs, care planning, managing critical incidents and emergencies, which happen differently in the LTSS population than in the medical population, and then the experience of the members in LTSS services, clinical quality measurement, which is similar to in the QI area, but here it's focusing specifically on the LTSS population, and then care transitions, because when we're looking at a population that is accessing LTSS services or in need of long-term support, they're frequently transitioning more often. They're accessing more services. They're needing services in the home, so the transition from an inpatient setting to a home setting, inpatient setting to outpatient support services is really important. So it's a big section of this area. Next slide. So I'm going to shift a little bit into how to read a standard, but I am sensitive to time, and so I'd like to ask our organizers, did you want to pause for any more questions at this point in time, or do you want me to go ahead right in?
Let me just ask one question. So as you walk through the MBHO accreditation standards from kind of the perspective of what would be the advantage of a BHO going through the accreditation themselves, I wanted to go back to something that Latisha said in the previous presentation, which was that the automatic credit only applies if the organization is responsible for a function for 70% of its members. So if you picture a typical Medicaid population Probably about 50% of the population will use mental health services at any given point in time. There's an overlap of STD services where it's more, you know, the neck of the woods of 12% or so. I guess the question is if a MBHO was only responsible for delivering, you know, services in any given month to maybe 20% or 30% of the population, would it still make sense for them to go through and become accredited as an MBHO?
So I want to make sure. Let me try and frame the 70% and then see if that gets to your question. Because you are correct, not everybody accesses behavioral health services. What we look at in NCQA is if there are 10,000 members in the health plan, and that's just a number for illustrative purposes. If the health plan has 10,000 members in it, if someone wants to access behavioral health services, today I might need it, tomorrow Latisha might need it, is what percent of those 10,000 members would go to that behavioral health organization? So while only 2,000 of those 10,000 members might be actually using BHO services right now, and therefore working with the MBHO, is every one of those 10,000, if they needed it tomorrow, would they work through that MBHO? Are half of them working with that, would they work with that MBHO, and the other half with another MBHO who covers, you know, the other counties of the service area? So when we're thinking about that 70%, it's not about members actually seeking services, it's about the potential of the member to seek services with that organization. Does that get at your question?
Yes, thank you. That was exactly it. We had a series of pretty specific questions about credentialing that you just touched on. So I guess one is we're assuming from our standpoint that if credentialing was delegated, that every individual practitioner would need to be credentialed as opposed to agency level credentialing. Can you respond on that one? Like, what's the difference between, I know you have like a way of agencies being recognized in that process, but can you talk a little bit about the difference between agency level credentialing and individual credentialing?
Okay, and so I'm gonna let a little bit of my ignorance show and ask a clarifying question back, because I figure I'll only look dumb if I don't. When you refer to agency, what comes to mind for me is, say, a community-based organization. So, for example, I live in an area with a large retirement population, and there's a agency, Council on Aging, things like that. So when you use the term agency, can you clarify for a little what that entity is, and then I can come back and answer.
Well, specifically, community mental health agency, for example, where the license is held at the agency level, but it includes, you know, some licensed practitioners, some non-licensed practitioners, some support staff, et cetera.
Perfect. Okay, thank you. That helps, because that's what I thought you were referring to. But agency can also mean like the state agency. So I wanted to make sure. Yeah. Okay. So when you're talking about an agency, NCQA distinguishes between practitioners and providers. And for us, a practitioner is a person, and a provider is an organization or an institution, or you know, a hospital. Or in this case, a provider can be an agency. And so what it will really come down to about what the expectation of the plan or the behavioral health organization for credentialing is going to be, what's their relationship with the practitioners at that agency. So let's say a community mental health organization or agency that has a series of master's level psychologists, social workers, and maybe even one physician or nurse practitioner. When the plan is contracting and when the plan is directing a member to the services, are they doing that to the individual by name or just to the agency? If they're listing each of the individual practitioners that work at that agency and a member would go to that person looking for that person by name, and the contract is with a person, then we would expect that behavioral health organization or plan to be responsible for directly credentialing that practitioner. If the contract and the steering, for lack of a better word, is to the agency by name and not to the individuals, then we would expect that the organization, the health plan or behavioral health organization, is credentialing the agency and is assured that it has all its appropriate licenses and credentialing, and that one of the things it does is it credentials its practitioners, that the agency is credentialing its practitioners. But that the fact that the contract and the direction of members is to the provider itself and not to the individuals is what determines the relationship. Latisha, is there anything you would add to that? As I asked Latisha to find the mute button. Okay.
Sorry, yes. No, you did a great job summarizing it. Thank you.
Okay. Did that help?
Yes, thank you.
You're welcome. Any other questions? Okay, so we've got about 15 more minutes. I'm going to try and cover my slides in about half of that to leave a couple more minutes for questions. So what we do with these slides is we just like to outline when we're talking to people who are new to the standards how to read a standard. And I'm not going to go through everything that's on these next couple slides, but there's different parts of a standard where when you're reading, you're going to find different information. And the first part of the standard really is about the organizing principles. In this case, standard QI2 is in the QI category and it's number 2, and that's sort of the organizer. And the statements at the top just provide very broad information. An important area of the standard right below that is a summary of changes. And the reason I point this out is each year when we publish the standard, we highlight major changes to any of the requirements in that standard. We do that from year to year. And so an organization goes through a review by NCQA every 3 years, which means they'll go through on the 2017 standards and the 2020. But those changes only refer what happened to 2018 to or 2017 to 18, 18 to 19, and 19 to 20. So if an organization is only looking at the standards every 3 years, they're going to miss changes that we try and call out. So we like people to understand the context of that when they're reading the standards. The real meat of the standard starts in the element, and element A, committee responsibilities, is where we really score an organization. And we look to identify the key things that we think need to be done to meet the element in the factors below that. So in this case, we're talking about the committee and the things that we think your QI committee needs to do, recommending policy decisions, evaluating the results of activities, identifying actions, etc. But those are pretty broad statements. And so if we flip to the next slide, we're going to take a moment and just say, well, how does an organization interpret those statements? So the next sections talk about how to understand those statements. The first part is the scoring, which is understanding what the implications of meeting those statements are. So that element has a point value assigned to it, the same way a question on a quiz has a point value. And a certain percentage of the points will be received based on how many of those sub-bullets or factors are met. So it's important to know that scoring to understand what's involved in meeting the standard. The next areas describe the types of documents we're looking for, documented processes or reports, and I'll talk about those again in a minute. And then sort of the scope of the standard. If an organization has different product lines, how do we look at it across those product lines? If it's a first time going through survey versus a renewal after previously being accredited, our expectations are going to vary. We expect more of a track record on a renewal. And that's similar in the look back period where we talk about the specific time frame of that track record, whereas the scope of review really describes what type of documentation we're looking at throughout that track record period. And then the next slide. The next two sections really help understand the meaning of those factors. And the explanation goes into details about what those requirements mean in terms of definitions. What do we exactly mean when we say analyzing and evaluating information, taking actions, etc. And then the examples are intended to be illustrative of what we mean. We're often asked, do you have to do everything that's in the examples? And the answer to that is no, you don't have to do everything that's in the examples. But some people comprehend information differently. Some people do better when things are described to them. Some people do better when things are illustrated to them with, here's an idea of what this looks like. Some people are visual, but we can't really make a movie of all the standards. So the examples are just intended to provide a different way to understand what we're looking for in an illustrative way. So that's a very high level on what to look for in the standards. The explanation is really important. There's a lot of details about what the requirements mean in the explanation, and we encourage everybody to really take time to read that closely. My last four slides are talking, next slide please, are talking about the types of documents. And we refer to different types of documents in broad groups. And the first one is documented processes. Documented processes I think of as past, present, and future, because they are written descriptions that describe how to do something and how the organization has done it, is currently doing it, and really effectively is pledging to do it going forward. They don't have to be policies and procedures all the time, although some places the standards actually call out for a policy and procedure. They might be flow charts, they might be call scripts, but the important thing is that it's how does your staff know how to do something. So if the person who has done that function for 20 years hits mega millions tomorrow and never comes back to work, is somebody else going to be able to do that function and pick up because they didn't hit the lottery? The next slide, please, talks about a document called a report for us. And if policies and procedures describe how something is done, reports show what was actually accomplished or what was done. So you can think about a key indicator report that gives the average speed of answer for phone calls as being a report. It's a report of performance over time. Meeting minutes are a report of what the committee actually did, whereas the policy and procedure that says how often the committee will meet and who will attend is its documented process. Its minutes are a report of what it did. And then the next slide, please, covers materials. And materials communicate information. So when we talked about having a member's rights and responsibilities statement, or having a description of information that goes to members that describes their benefits, those would be materials. It might be their benefit booklet. It might be a newsletter. It might be a web page, but they communicate information, and that's the difference between a material and a report, where a material describes what happened. A report describes what happened or shows what happened. A material helps somebody understand what's going on. And then the last data source is areas where we pull records or files, where we're actually going to sample, for example, 30 denials that have been rendered by the Utilization Management Department to see what was the clinical information that was the basis of the decision. Did a physician or a PhD level behavioral health care practitioner make that decision, the denial decision? what was told to the member in the letter that went out to them, etc. So we'll select a record to actually review and score the organization based on the record. That's kind of a high-level intro to the standards and how they're organized and the information that's in them. I know we did cover a lot. The only last slide we have is we were asked to provide some information about the cost of going through an MBHO accreditation in terms of our fees, which is sort of just what our fee is to undergo a review, which is not necessarily the cost an organization, its resources to prepare for it. And these are effective for surveys starting July 1st of 2018. We tend to update our pricing no more frequently than annually. So with that, I'm going to open the floor up for questions. I think I did just about half of that time, so we've got about 7 minutes left on our agenda. And I'd say questions to any of Leticia or Jennifer and I.
Thank you. We had a question that goes back to the question we were asking about in the last group, which is if in the agency or provider credentialing example, you said that the, for example, MBHO would credential at the provider level, but the provider would be responsible for verifying the credentials of its practitioner. So is that considered sub-delegation?
Not necessarily. And I know that's kind of confusing. So bear with me, I'm going to try and illustrate it. In the case of the agency where an organization, where a plan, I'm going to say plan because while a BHO may not be a plan, I think if I use plan, we're all clear at the same level that I'm talking about. Organization can be confusing. If a plan is directing the member to the agency, and then the agency has to credential the practitioners, that's different than, say, a plan delegating credentialing to a hospital where a member could still choose the individual surgeons at the hospital. And so the plan would be expected to know that those individual surgeons are credentialed, because when I go to get back surgery, I'm going to actually look up a surgeon and do pick a surgeon. And in that case, the plan is still expected to credential the individual, and they might delegate that credentialing to the hospital. But when the direction and the contracting is only with the agency, then there isn't actually an expectation of the plan being responsible for credentialing. So they're not delegating that responsibility to the agency. And if I stay at my hospital example, while I may pick my surgeon, I'm not going to pick the pathologist. And so there isn't an expectation for the plan to credential the pathologist, although there is an expectation that the hospital probably is. Does that help?
Yeah, that's very helpful. Thank you.
It's in the first credentialing standard, there's quite a bit talking about sort of who has to be credentialed in the explanation, and the focus really on that idea of where is the contract level and where is the direction or the steerage. What does the member understand about direction? And I think that'll be useful information.
Yeah. We're just curious, as long as we're still on the pricing slide, these are additive fees, so it would be a base fee plus the application fee plus the per enrollee fee. Is that right?
So the application fee actually applies toward the base fee. So the $15,000 application fee is paid at the time of application, and that is non-refundable. And that applies towards the $39,500. So then the next portion of the survey fee would be $24,500, and then the enrollee fee is additive above that.
Thank you. We had a question about the look-back period. So in our example, MCO will not actually implement the delegation to the BHOs until January 2019. So does that mean the look back period would not be until July to December? Oh, no, it says, would this mean there's a look back period that goes back previous to January 2019?
Oh, that's a complicated question.
Yeah.
Because the look back period is defined for the health plan based on when it's undergoing its survey. So the look back period is counted back from the date of the health plan survey. And so where the timing of the credentialing or the delegation falls into that, it's not an easy answer.
Okay.
I almost need to be in the same room with a whiteboard.
That's okay.
Because it does depend a little bit on the function and the timing of the health plan survey.
Yeah. I think we'll hold on further questions until after the managed care plans, but thank you so much, Leticia and Anne and Jennifer, for being on the call and helping us understand delegation requirements. If you could please stay on until 12:30. If any other questions come in about NCQA would be helpful to answer, we would appreciate it. The next presentation, we asked Patty Jones and Shannon Rochon, Patty from CHPW and Shannon from Molina, to talk about the work that they've been doing as all the health plans together on trying to administratively simplify delegation requirements. So Patty and Shannon, take that away, please.
Great, thank you. This is Shannon Rochon. I'm Manager Delegation Oversight for Molina Healthcare, and I am going to start off our small section today. And Patty and I have just about 15 minutes, so I'll try and move quickly. That way we can leave time for questions and answers. Next slide, please. This first slide here is an introduction. Basically, all of the MCOs have collaborated on a process to identify the BHO's proposed delegated function. This saves the BHO's time and resources for having to set up specific time with each of the MCOs for their review separately. So we're taking it in one swoop, trying to make things move smoothly. The MCOs created a Excel spreadsheet, a tool that the MCOs are calling its free screening questionnaire. And that includes questions for the BHO to complete about their organization, how it operates, the credentialing, case management, and claims functions. By the BHO completing the questionnaire for the MCOs, this allows time for the MCOs to review for any additional questions or clarifying responses prior to that pre-screening call. It also provides the MCOs what areas the BHO wants to be considered for delegation functions. That pre-screening phone meeting is scheduled with all of the MCOs and the one BHO, all at the same time. The MCOs arrange for the appropriate departments to participate on that call and review of any responses on that questionnaire. Question and answers, explain the next steps, and Patty will go on more about that later on. All the MCOs must agree on the same delegated functions. If determined by each of the MCOs the BHO meets the requirements needed for delegation, all the MCOs must be in agreement to delegate that function or functions. Next slide, please. Thank you. The following MCOs that are participating in our group are AmeriGroup, Community Health Plan of Washington, Coordinated Care, Molina Healthcare, and United Healthcare. Next slide. Patty?
Thanks, Shannon. Good morning, everyone. This is Patty Jones. I'm Senior Vice President of Health Services here at Community Health Plan of Washington. And Leticia and Ann, I'm the same Patty Jones who is a surveyor and has had the chance to work with you folks over the years. So really appreciate that really fantastic overview you gave of the NCQA process, how to think about delegation, and how the standards are constructed. Working with Shannon and our other colleagues in the NCOs, we really have been thinking hard and working together in terms of what are some ways we can make this easy and work collaboratively to move this forward. Latisha did a great job of essentially outlining what is on this slide. And what we are working on is creating some joint tools that we will work with each of the BHOs on that although there may be times that we have to have some specific customization of some things like contracts, that type of thing, we do want to move towards some establishment of some consistencies in terms of delegation agreements and how they relate to the different functions that each of your organizations may be interested in pursuing delegation around. Some consistency in what we're expecting in terms of how we will obligate ourselves to provide member data, as Latisha outlined, is a responsibility of ours as MCOs. And then, especially once we get into the pre-delegation capacity evaluation, that is something where there may be some opportunities for us to do that as a team of MCOs versus 5 individual MCOs conducting that activity separately. So we think there may be some true efficiencies there, and then some efficiencies around how our audit processes and the reporting requirements. So talking points on this slide really are that we are working together as MCOs to try and streamline, create consistent tools that support the needs of our customers here, HCA and CMS, as well as the NCQA standards. Next slide, please. And just quickly, developing what that will lead to is some common tools, some support and education for you. We encourage you to use the resources at NCQA. They've got wonderful training materials, training sessions. The standards, it's really worth purchasing the standards and getting familiar with them. And we'll be here to support. And then once we do have delegation in place, ongoing auditing, that's another area where we think there may be opportunities for us to conduct that jointly. So thank you very much, and we look forward to working with all of you, and I'll go on mute and let questions come forward.
Hi, so don't go on mute too quickly. This is Alice. We already have a couple of questions. One is on your expectations around delegated credentialing. Would it be more typical for the MCOs to have the contract with the National Practitioner Database, or would you tend to delegate that to the BHO?
So one way to think about credentialing is a terrific subject because, as Ann said it, and Latisha also, it's one of the more straightforward aspects of credentialing, and it's of delegation, excuse me, and it's a common part of what health plans have responsibility for that gets delegated. If you think about credentialing and the standards, it's almost a la carte, and that a BHO might elect that you want to do that first, the primary source verification part of credentialing, but not the decision part, or maybe you want to do both. So once you determine, or once the BHO determines that it would like responsibility for certain aspects of credentialing, you're then expected to follow the standards and the expected processes around that. And then what the health plan does is we just evaluate to make sure that you're doing it in accordance with the standards. So if you were to take on primary source or verification of certain aspects of credentialing, such as checking with the NPDB database, your organization or the BHO would typically be responsible for having that contract in place, typically. Shannon, I don't know if you or some of our other colleagues want to add to my comments.
Thanks, Patty. This is Shannon. And yes, I totally echo you in that credentialing is the most common, straightforward standard that we could be dealing with. And the most common way that it is set up is that if the BHO did want to move forward with that, they would have to have their own contracts, just as you had said.
Thanks. A question came in earlier, and I thought maybe you guys could answer this easier than NCQA. Would you consider the Behavioral Health Administrative Service Organization to be a covered entity for the purposes of delegation?
This is Patty. We're not lawyers, but I'm going to say probably yes. So, you know, it's very typical practice these days to establish, you know, a BAA between organizations. We may already have some in place with some organizations. So, highly likely yes would be my response.
We'll check on our legal side too. What is the time frame for the MCO's decision on whether they'll delegate certain functions to the behavioral health organizations for 2019?
Well,
that is a great question.
This gets to some of that look back period. This is Ann. You know, really, the reality is a plan can choose to delegate or stop delegating at any point in time. It's like any contract. There's a process you go through. You know, if I want to contract with someone to remodel my kitchen, there's a process of figuring out what I want done and who's got the capability to do what I need, and then who's the best one to do it. But even once that happens, it could be a couple months before the person actually shows up and starts ripping up the floor. So that process is going to vary for every plan and every delegate, given the scope of the services that they're looking to delegate and the capacity of the delegate. You know, and that's why that look back period question is kind of hard to answer, because in the same way all of it's tied to when a survey is for an organization, it's also tied to when that contractual relationship starts.
Right.
There's nothing that prescribes the way that timing has to work, only that before a plan actually has a delegate starting to do work on their behalf, they need to make sure that the delegate has the capacity to do it and that they've agreed in writing with each other who's doing what. So, you know, it's similar to my kitchen renovation. I want to make sure that my contractor can do that work and that we have a clear contract that says what I'm getting charged for and what he's doing and what he's not.
And then from our perspective at the Healthcare Authority, I think as we said in the transition year memo, that we would expect to see some evidence of those decisions at the time of the RFP. So as the MCOs start responding to the RFP, which will be somewhere in the neighborhood of mid-April, we would expect to have those decisions starting to be firmed up. A question came in about who this process applies to in terms of transition year behavioral health organizations versus not. So it says if a BHO is either a mid-adopter or an on-time adopter, which means 2020, will the pre-assessment occur at another time? So Again, anything that the MCO is going to turn around and delegate to the behavioral health organization would be part of this process. However, we would not really expect to see the 2020 agreements in place at this time. That would occur at a later time.
Right, and this is all. I just think it's important to understand that for BHOs that intend to become the ASO, regardless of the transition year, the managed care plans are going to be delegating responsibility for the Medicaid crisis benefit. So there is, regardless of transition year, there is delegation that comes with delegating responsibility for the crisis benefit. And I would agree with Alice that for 2020 regions, I don't think we would expect to see the details yet of delegation worked out in the RFP.
Okay, I think we don't have any more burning questions from you all, although I'm sure this raised a lot of good issues. Really, really appreciate Patty and Shannon also coming on and sharing the perspective from the MCOs. We are, as always, in touch with you all very regularly, and we'll continue to keep an open dialogue as to how all this is going as we move forward. The next learning collaborative that we intend to have will probably be after the RFP period is concluded, so you won't hear from us in this same forum or opportunity, but I'm still happy to have conversations one-on-one with folks and answer questions as much as we can, and really appreciate that NCQA has made themselves available to us to help answer questions too. We wanted to say that we also have the assistance from our friends at Mercer and the Center for Healthcare Strategies, who assisted us with putting this webinar together today, and they have been most instrumental in getting the right focus for this webinar and the education that you received today. So I just wanted to point out that they have also been listening in and did a lot of work getting us to this point today so that we could share this information. So thank you very much for all of your active participation. Please do continue to send questions by email after the conclusion of today's webinar, and we'll get them answered to the best of our ability, and we'll pitch the ones that we can't answer to our subject matter experts. Thank you again to NCQA and to the MCOs and to all of you behavioral health organization participants. Really, really appreciate your involvement today and helping us to get to 2019. So that concludes the webinar for today.